Thank you very much, and good afternoon again. To complete the overview of this new technology, new procedure, I'm going to show you these results. As Dr. told you, there's an increasing influence of this technique because we need to overcome the changing on other techniques, but it's true that nowadays there is a lack of randomized controlled trials, so we don't know exactly if what are we doing. But we feel, the reviews show us as conclusion that the procedure is safe and it's feasible in our patients. It has at least the same morbidity as the laparoscopic approach, and it has promising oncological outcomes. But are we doing well? We should ask this question to know if we should continue in this line of work. So I'm going to show you the results today of the procedure. First of all, these are two works that we have published. One was with our initial experience in laparoscopic approach, and the other one was our initial experience in transsonal approach. When we evaluate both works together, it's true that it's difficult to compare them because we have different previous learning curves. Nowadays, there are different adjuvant treatments than 10 or 20 years ago, but at least we think that we have similar results at the beginning, oncological and in terms of morbidity. And when we evaluate the operative time, we can decrease this operative time. And when we evaluate the recurrency, as you can see that the local relapse, it's much lower in the transsonal group than in the laparoscopic group. But I'm going to focus in our actual experience in the transsonal group. We have made, as I told you, 252 patients. These are the baseline characteristics, always more males than females. The mean of BMI is 25. Most of them are to the anesthesiologist's classification. The mean distance from the anal verge is 7.8, but as you know, we have made low, middle, and high rectum. There are subgroups that only focus in the low rectal cancer, but we have tried all kind of rectal cancer. And almost a half of our patients received neoadjuvant treatment. Now, this is one of the most important slides. This is the surgical outcomes. We could reduce the surgical operative time with a mean of 147, with a minimum of less than 1 hour in treating a rectal cancer. In terms of the anastomosis, probably there is a limitation to this result because, as I told you at the beginning, we only perform hand-sewn anastomosis, but nowadays we prefer a mechanical anastomosis end to side when it's possible. The mean of the height of the anastomosis is 4.7. And about the splenic flexor mobilization, as you see, we only have a 33% of a splenic flexor mobilization. There are some groups, especially, for example, in Oxford, they usually mobilize the splenic flexor, but we think that we only should do it when we need it, when we think that there is tension or traction on the colon. We don't do it in every patient. We use an assisted incision to extrude the specimen in a 44%. And one important thing is the high percentage of diverting stoma. We are still using a high percentage of diverting stoma, probably because a high incidence on neoadjuvant treatment and the high incidence of low rectal tumor. We prefer to protect the anastomosis. The other table talk about the intraoperative morbidity. That's at around 10%. But when we evaluate with CUR, this table, you see that there are a lot of complications that are not related with the technique itself, with the transsonal approach itself. We had to reduce a myelostomy, some small bowel injury that it's not related with the technique. One of the complications related with the technique could be the ureteral lesions. We have one lesion that could be solved by laparoscopy also. We had one injury of the seminal vesicle, while one rectal damage with the manipulation of the tumor. We have to reduce the anastomosis in 3 occasions, 2 due to an ischemic of proximal colon and 1 of colonic damage during the anastomosis. So we have to change and perform hand-sewn anastomosis. When we have 1 damage of the vascular arcade and 1 bleeding of the hypogastric vessels that was solved also by laparoscopy. So it was a small complication. Talking about pathological outcomes, one of the most important that is going to influence in the oncological results of our patients is the mass rectum, that it was complete in 97.2% of the patients. It's a quite high percentage. We have an affection of the distal margin in any case, and about the circumferential margin, the mean is the 10 with a positive rate of 5%. That, if you remember, the most important works about open laparoscopy, it could be up to 80%, so it's really low. The tumor perforation, it only happened in 3 cases. And another important item, that is the lymph node harvest. 70% of our patients get more than 12 lymph nodes on the evaluation, and the mean is 60 lymph nodes. Talking about postoperative outcomes, we are also having good postoperative outcomes. The morbidity rate is around 35–40%, that it's really similar than other series, and especially when you compare laparoscopy and other approaches. And we only had 1 case of mortality that it was due to a cardiac infection. It wasn't related with the surgery. We have 10% of reoperation, but the same as the other complications in 4 cases were not related with the technique, were related with problems with the ileostomy. So we have evaluated carefully when we should make the ileostomy. And another problems where we had to perform in 3 cases a Harman due to problems with the anastomosis, and a diverging colostomy in 7 cases to protect possible leakage, and hemostasis in 1 case, and a transrectal drainage in 2 cases. And the Clavendi classification, 60% of our patients had no any kind of complication. In the mid and long-term results, the follow-up nowadays of the whole series is a mean of 23 months. The time to recurrence has a mean of 12 months, and as you see, the recurrence has a rate of 50%, higher in the distal recurrence with a 12%, comparing with the local recurrence that is just a 4%. The disease-free survival has a mean of 46 months, and we only have 11 exitus in the whole series. So nowadays, 79 of our patients are alive without the disease. So it's really important, our results, but it's more important to see what is happening in the rest of the world. So there are these are the 2 most important reviews talking about the TaTME. The first one, the higher one, is from the Oxford group, but it's one they published 1 year before, and the last one was published this year, and it's a higher number of patients. So I'm going to talk about the results of the second one. This is all the papers that they include. They include 33 studies, comparing with the other one that include 36. The most important thing that I would like to transmit to you, is that there is a lot of works, but a lot of heterogeneity between these works. Not all of them study the same items, the same factors, so it's really difficult to compare the works and have strong conclusions. But I will try to show you some of these results. These are the demographic results of these papers. The most important is the only 40% of the surgeons are using the TEM on TEO device. The other surgeons, most of them are using flexible platforms, gel-pon, 3-pore, seals, but flexible platforms that are more comfortable for the surgeons. About short-term results, it's a quite short operative time. About intraoperative complications, I think that in this paper, perhaps we are missing some complications because they describe, yes, 2 urethral lesions, but in the other paper there were 3. And I know in the papers there are at least 3, so perhaps with this heterogeneity between the works, we are missing some complications. But in globally, I'm showing the absolute numbers because they don't show percentage, yes, the absolute numbers, but you see that the absolute numbers are quite low, and we think that we are doing well. And also in the pathological results, if you sum up the patients, when we evaluate the quality of the mass rectum, they don't sum up 700, they sum up 450 more or less. So it's again that all these works don't include all the factors that we should study in the rectal cancer evaluation. But as an idea, you see that most of the patients has a complete or nearly complete mesorectum with a lymph node harvest between 11 and 30, with a percentage of positive circumferential rectal margin between 2% to 50%. So they are quite good results. So nowadays, there is a lack of randomized controlled trials. The transanal total mesorectal excision may be considered feasible and safe, but there is a promising evidence of oncological safety, but we instill to continue our study. But I think it's essential not only to know what we are doing today, but to compare with our gold standard nowadays that in our hospital, in a lot of hospitals, is the laparoscopic approach. So I would like to show you here a small comparison between the laparoscopic and the transanal approach. This is the same as before, our own comparison. We compare the last 37 patients made by laparoscopic approach and the first 37 patients made by transanal approach. As a global conclusion, there were no significant differences on baseline characteristic, but there was an increased colonal anastomosis. As I told you at the beginning, we only made Hansen anastomosis. There was an increase on ileostomy with transanal approach. Probably we began with lower tumors and low rectal cancer in most difficult situations. No pathological differences, no significant postoperative evolution. The morbidity was lower in the transanal group, and also the readmission rate was lower in the transanal group comparing with the laparoscopic group. If we evaluate the follow-up at 2 years, it's true that the follow-up in the laparoscopic group is longer than in the transanal group, but as a general idea, you see that the overall survival was really similar in both groups. And talking about recurrences, there were no significance, but there were lower distant recurrence in the transanal group than in the laparoscopic group. And the disease-free survival was the same. There were no differences between the two groups. So the evaluation of the short-term outcomes demonstrate that transanal is feasible and safe technique associated with shorter surgical time and lower early readmission rate. The transanal total mesorectal excision seems to be an oncological safe alternative for the malignant rectal cancer, but we need longer follow-up. And the only review that compare laparoscopic and transanal approach is this one that is from China. It's from this year, some months ago, and it's the only one to evaluate, like as a review, as a meta-analysis that was conducted to compare the oncological and perioperative outcomes. They include only 7 works, including 573 patients, 217 in the transanal group, and 303 in the laparoscopic group. Yes, a puntualization, there is only 1 work that was a randomized controlled trial. The other ones was matched case controls. And the other thing is that 2 works, the Cancer et al. Work and the Nost et al. Paper, they only talk about low rectal cancer. They don't focus on middle or high rectum. And what they see, they conclude that the transanal total mesorectal excision get a shorter operative time, a lower conversion rate with an equivalent hospital stay, higher splenic flexor mobilization, probably due to the 2 of these works only focus on low rectal cancer, so they have to mobilize the colon, the splenic flexor, a lower rate of postoperative complications, and an equivalent rate in anastomotic leakage, ileus, and urinary morbidity. And about oncological outcomes, we have a better quality of the mesorectum in the transanal group with a percentage between 80 to 100% compared with the laparoscopic group, where the percentage was between 72 to 90%, so it was lower. The harvest lymph nodes was equivalent in both groups, between 12 to 20. The circumferential margin was better in the transanal group with lower number of positive circumferential margin that was around 5% comparing with the laparoscopic group that I remember you that was up to 16% and in some cases up to 18%. The distal margin affection was equivalent and the involvement also equivalent. So these are all the works that I showed to you this afternoon, but of course we have to compare with our reference, that is the Coloproctology trial. Just a fast view about the comparison with our results, our own results with the Coloproctology trial, the baseline characteristic was almost the same, but when we focus on the surgery, we see that we have lower operative time, as I told you before. And about the pathology, we could reduce the positive circumferential margin to 5%, and we increase the lymph node harvest. And also, in the mesorectal quality, we have a higher number of patients with a complete or nearly complete mesorectal, as high as 97%, comparing with the 90% or 88% in the both branches of the COLOR2 trial. And finally, on the positive outcomes, the mean of discharge is also lower, comparing with the both branch of the COLOR2 trial, and the anastomotic leakage was slightly lower if you compare with this trial. So we consider that laparoscopic assistant is currently necessary in the transanal approach. The pure nodes is just for a specific center for very specialized surgeons. The short-term oncological outcomes in transanal total mesorectalization are comparable with laparoscopic and open approach, and randomized trials are necessary. And this is the randomized trial that it's taking, that's going to be done in Europe, comparing the laparoscopic versus transanal approach. It's going to be a superiority trial with a 2-to-1 distribution. The primary outcome will be the positive circumferential margin, less than 1 millimeter, and the sample size expected will be 300 for laparoscopic group and 2,300 for transanal group. So we will have to wait for the results of this trial to be convinced about this technique. And just this slide about the robotic and the transanal. Of course, the innovation and the evolution goes together, and we not only evolve in the treatment by robotics, but also by the transanal, and Atala has combined both techniques, making the robotic surgery through the anus. But it's expensive, so we have to evaluate the results before using all around the world. Thank you very much.